especially this morning. Great to see you. I'd like to thank Waltham for inviting me to do this, although I'm still a little bit upset that they moved the meeting from Sao Paulo here, but oh well, I've not been outside much anyway, so it doesn't matter. I will talk you through lots of data. Actually, my background is in animal physiology. I did my undergrad training at the Agriculture University in Wageningen, which I actually saw some posters, which is cool to see. But moved into the clinical science more and more, and nowadays are basically involved only in human clinical studies. Let me see how this works. That's forward. Can I get my slides up? There we are. I will take you through several things. We'll spend quite a bit of time on methods that at least we use in the human field to study muscle mass and the mechanisms behind muscle mass. I'm very, very biased that I like turnovers. So we'll see a lot of turnover data as a kind of mechanism behind the wasting things. So my disclosures here, I lecture for, I don't own a pet, which I thought was a little bit boring, so I put my favorite cat on there, and he will help me through a little bit today. A little bit on the research we do before we go into the sarcopenia. We'll spend a lot on aging, but we have a research group that is interested in the extreme of muscle wasting. These are the patients, and it says here that the research group is actually dedicated only to the nutritional and metabolic problems that patients have that are treated in an intensive care unit. So these patients lose muscle mass the fastest. About 10% per week in the first weeks is just lost. Intensive care units are slightly different between different countries. And Europe has the disadvantage that we normally have very small intensive care units. And the patients coming into the unit have different backgrounds. Like you see here, different reasons. But since the ICUs are small in Europe, only the very, very sick come into the ICU for treatment. And these are the ones that develop this multiple organ dysfunction syndrome, where the different organ systems start failing, and without support in the ICU, patients would actually not survive. This is the kind of group that we do our research on, mostly because we have a hospital with abdominal surgery. We get a lot of the sepsis patients in there. So you'll see through the talk a couple of these data, more to show you the extreme of wasting. This organ failure, of course, is a problem, and this is just showing that the more organs that are actually failing in the patients, the higher the mortality. If most of your organs are failing, of course, you get into about 80% risk of mortality. A little survey that we did a couple of years back, which is the kind of group that we are really interested in intensive care in our hospital. We, over 1 year, looked how many patients we treat, and we have two groups of patients. It's patients coming in and out. A lot of the liver transplant patients just come for observation a couple of days. But it's these patients that we can't get rid of. They're in the ICU very long. They consume a lot of the resources that we have, and also there is where the mortality is. So this is really the group that we are interested in, and where nutrition is going to make a difference. If you're only in the ICU for 1 or 2 days, the nutrition in the ICU is probably not going to help. It's the overall nutrition. It's these patients that lie there for a long time, with people in the unit for months, where nutrition actually helps. Nutrition in the ICU helps that particular patient. Okay, what are we going to look at? I'll take you through these step by step. We'll look at muscle mass, we look at the methods that we use in the human field, we look at the wasting, aging, disease, we look at how do we gain muscle mass. A lot will be on the mass and muscle function, of course, and then a little summary there, what's the meaning of all of this that I actually have told you. Before we go there, some definitions. There's a lot of definitions nowadays in this field, and there's definition papers coming out all the time. I didn't feel like reading all of them, so I just used Wikipedia, which actually gives you a very, very good idea what we're talking about. Sarcopenia is a degenerative loss of skeletal muscle mass with age, and it's not just the mass, it's also the quality and the strength associated with aging, and it's part of this frailty syndrome, and we'll come to that a little bit now and then, I will mention it. Frailty syndrome, according to Wikipedia, is a common genetic syndrome that embodies an elevated risk of catastrophic decline in health and function among the elderly, and this is really where the problems in the elderly come. And then we have this other term, which is cachexia, which is a more disease-induced muscle wasting, and you can have that white in many diseases. It's an involuntary loss of muscle mass and loss of appetite and loss of function. So just to put these three a little bit separate. I'll have a few of these things where I'll just point out what my thoughts are, what is important. And I think one of the things that is very important in clinical nutrition is this kind of, when we're fasting or not feeding right, most of us have enough to survive a couple of days or weeks without energy. We can supply that, and actually for some of us it's actually an advantage. We do this voluntarily. The problem is with protein. We don't have a real protein store. The protein storage in our body is mostly in muscle, but it's a functional thing. So you don't want to lose it, and still it's something that you lose when you're not eating. Just some facts on muscle. We have lots and lots of muscles, different muscles. 40 to 50% of our body weight is actually muscle. It's important for walking around, for standing up, for breathing, and also it has a lot of metabolic actions, partly for producing heat. It comes in fibers, long cells that actually do the contraction, and if you zoom in to that, you see I'm hitting the wrong button all the time. You see the proteins there that are important in the muscle that we'll come back to a little bit, the contractile proteins, the actins and the myosins that actually move into each other to make the contraction happen. There's of course the blood supply, and then you have a lot of mitochondria there to produce the energy for doing this. There's two different types of fibers that we have in there. I'll come back a little bit, not that much actually. We have the slow fibers and the so-called fast and the very fast fibers. These are metabolically different. The slow ones are, of course, they can produce not that much power, but they can do it for a long time. Important fibers when we're actually doing long distance running. And you have the fast and the very fast, which become more important for kind of explosive muscle power production. And they actually cannot keep that up for very long. The clinical consequences. We know there's wasting. What's the problem with this? And this is, a lot of them are actually correlations rather than absolute studies. You cannot just have somebody waste muscle and then make them older or give them a disease and see what happens. In the elderly, it's very obvious that the more frail you are, the more loss of muscle mass and function you have, the more falls you're likely to have, and the more likely you actually are going to be breaking those bones and have to go for surgery. In general, this is an interesting study, a Nutrition Day it's called, where different hospitals around the world report into the database that is used. And this is BMI, wrong button again. BMIs measured in lots and lots of patients, about just over 16,000 in hospital BMIs, and look at 30 days in hospital mortality related to the reference. You see low BMIs, low body mass, low muscle mass actually is related with much higher mortality. This is actually the more interesting thing. We will not be talking about this. The obesity paradox. People that actually have a higher BMI have higher survival rates in many, many situations. Too complicated for me, so I won't talk about it. Cancer cachexia, of course, a huge problem. There's patients with massive amount of cancer cachexia. Of course, there's patients with less. But one of the main problems that these patients experience is that once The cancer patients with sarcopenia, so really serious muscle loss, have much more toxicity from their chemotherapy. For two reasons. Partly, I guess, because they are weaker, but also we give chemotherapy always per body weight. And if that body weight is different because there's less muscle, especially in the sarcopenic obesity, this could be a problem. In our group, the critical ill patient that we study, if you measure muscle mass, we'll come to the techniques later, some way, and you divide them in groups with higher and lower muscle mass, you see the ones that have little muscle have actually survival rates that are scary low. So the methods. What are the methods? I will not cover all methods because there's too many, then I would be standing here all day talking to you about methods. But I will cover the ones that are used a lot in the clinical nutrition and aging, because we're talking a lot about aging. I split them up in three groups: body composition, biochemical, and functional measurements. A little bit about the BMI. I showed you that graph with the different things in the hospital and survival. We have this massive problem, not massive, but it's getting more and more, of sarcopenic obesity, which means that actually you can have two types of obese patients, or persons. You have the ones that actually have a decent amount of muscle mass, or actually more muscle mass than normal because they have to carry around the weight. And you have the ones that actually have very, very little muscle mass. You don't see this on the outside. They're all big and you don't see it. If you look at CT scans, you then actually see, and the DEXAs, you can see this. So just BMIs doesn't tell you always, and especially in cancer, cachexia have been shown that this is a big problem. If you have the hidden sarcopenia there in this large body, your toxicity to the chemotherapy is very, very much different. So a method that's used a lot is, of course, the DEXA scans. It's a dual energy X-ray absorption, where you put the patient, and it's, as you know, probably it's mostly designed for looking at bone mass, but it gives you on the side also distinguishing between lean body mass and fat mass. And if you then take the lean body mass in the legs and the arms together, you get a pretty good estimate of muscle mass in patients. This, of course, is only possible in patients that can make it to the machine, can fit on the machine, lie still on the machine. So it's a lot of problems there. But still, I think in the clinical nutrition, it's becoming more and more of the golden standard. CT scans or MRI as well are visualizing techniques that can do this very nicely. You can do that in the leg and really see the muscle mass. What's become extremely popular in the fields I am in, cancer, cachexia, critical illness, is actually estimating whole body muscle protein from one single slice CT scan on the L3. This comes from the cancer field, developed mostly in Canada, because most patients have cancer in the abdomen, and that's why they have the scans. So the clinically available scans that you can pull up, you don't have to send the patients there to do a CT scan just for the muscle mass. And there you can actually calculate the muscle mass in that slice, and it correlates very well with whole body muscle mass. So it's a technique coming up more and more. What I always think is that when you're interested in something, you should measure what you're interested in. And often we're interested in muscle mass or muscle function. One of the problems we have in the intensive care unit is that we can't measure muscle mass very well. We can't take these patients to the DEXA scan. So this is becoming actually a very, very nice technique that we can use, especially in the unit we have with a lot of abdominal surgery. We have these scans available anyway, clinically. This is a technique not used a lot, but I always take it up because I think it's a beautiful technique. It's potassium, which sits in your muscle cells, that actually has a little bit of radioactivity in there, that if you can measure this independent from the outside world, so you have to put the subjects in a kind of very isolated box, you can measure this and get whole body muscle mass. A very neat technique, but very, very difficult to actually do. Another thing that's becoming very popular in the clinic is ultrasound, where you look at muscle thickness or muscle circumference and then estimate. I don't know. It's very popular. We tried it. We couldn't get it to work. Reproducibility is very bad. So I think it might be something in large cohorts for the individual patient and see changes in muscle mass is, I think, never going to work. One of the things there is actually, if you do, especially the thickness, is how much pressure do you actually put on this. Yeah? Then these patients, especially in our units, they kind of retain a lot of water, and you don't see that really as a difference. Biochemical measurements is just more when you want to go and look why is muscle mass wasted. A couple of them. Most of the time, you unfortunately need a biopsy. In humans, rather easy, I guess, maybe even easier than in pet animals, because we just ask the subjects if they want to do it, and they say yes or no. But actually, I've had a couple. It's not very painful if you get the right clinician doing it, actually. In the biopsy, you can do that several things. You can measure these fibers that we talked about. You can count them. You can measure the fiber size and the relation between the different types. You can measure the protein content, which is something we do a lot. This is a slide from our patients again, that you see that during the time, the protein content in muscle is dramatically decreasing. So it's not only the size of muscle, it's also the 20% of muscle mass, which is protein, is declining even further, which is probably water retention. Dramatic drops that you don't see in other patients. I will spend a few minutes on turnovers, because I like turnovers. I get excited by them, actually. It's a bit sad. Most of you know that we turn over things, and in protein we actually eat, make amino acids, and then we kind of turn them around in the protein pool. And why this is important? I think it's important because it's the balance between the two that determine if you're losing. If you're wasting mass, yeah, what's doing it? Just some examples of real diseases, where if you look at the protein synthesis up, the protein breakdown down, and then the light one, there's the protein balance of muscle. All of these situations, you're wasting muscle, but it's completely different. You have a decrease in synthesis. Here you have an increase in breakdown, not much in synthesis. Here you actually have huge increase in synthesis, but breakdown is even more increase, and you still waste. So to really find out your patient group or the elderly, if I want to intervene in this, which side of the story are you going to intervene with? That's why I think turnovers are important. This is what we do. The human, we eat about 70. We actually turn over about 4 times as much. If you calculate this, do some assumptions, we replace our whole body's protein pool about every month. Of course, in there is all the tissues. They do different things. Muscle here that we're interested in has a very low turnover rate. But because it's so huge, it contributes a lot in mass and turnover to the whole body protein turnover, whereas the tissues that have highest turnover rates but are smaller contribute to a lesser extent. How do we measure these? Several techniques. They're all based nowadays in humans on stable isotope tracers. So you put a stable isotope on your phenylalanine or another amino acid, introduce this into your subject, and then you see how much of this phenylalanine that is labeled is incorporated in the protein pool as a measure of synthesis. Breakdown is more complicated. It's mostly done by, if you break down the proteins, it's unlabeled amino acid that dilutes your tracer. So how fast it dilutes it will give you an estimate of protein breakdown. Then if you put your label right, either 13C or other things, you can actually go and measure the losses, the amino acid oxidation at the same time. So if you do nutritional interventions, you can see if your extra protein is oxidized or not. If it's oxidized, it's probably useless because there's other substrates that are better for energy. And then if you do oral nutrition, normal feeding, you can add another tracer, a label, same amino acid, but different isotope on it, nitrogen instead of carbon, stable isotope, and then you can distinguish kind of uptake and absorption as well at the same time. For muscle, there's basically two techniques used. And this is, again, it's an important slide, so if you're not awake, wake up. The easiest technique, and that is used mostly, is here on the left-hand side. You introduce your labeled amino acid into the precursor pools, you inject it, or you can even eat it. There's different ways to get it in there, and then you measure the incorporation of this. So you take biopsies, or you can do then circulating albumin, take blood samples, and see how much is all incorporated over time. It's reasonably easy to do. Yeah? For muscle, it's a bit invasive, but it's a technique that people use a lot. Yeah? And the whole field, I think, is biased by that we measure only one side of the story. Yeah? The other side of the story, the breakdown, is actually more complicated to measure. Yeah? One of the techniques that's mostly used is that you assume that your leg here is only muscle, and you look at the fluxes to the leg, so the artery, what is supplying it to the muscle, and what's coming back in your femoral vein, or you do it on the forearm as well. And then you add a tracer labeled there, and you take samples before artery, the vein. Sometimes you need to get biopsies as well. You measure the blood flow at the same time, and then you can model this. Yeah? But it's more complicated. It's more invasive. You have to put, although it depends where you work. I work with anesthesiologists. They don't care about putting catheters anywhere. If I want to do an invasive study with femoral vein catheters or arterial, all the young doctors are standing there and they want to join because they want to test this. So for us, it's not a problem, but a lot of centers, this is a problem. Then, of course, what you do here, you do a lot of measurements, and then you start to model this and subtract them. So your variation in the method is much, much larger than here. Yeah. So, like I said, the field is biased because this is easy to measure, this is more complicated. And we'll see that when we go through results a little bit. How do we do this? We infuse normally, or you can do oral supplementation of the labeled amino acid. And then we do nutrition interventions and take samples, either blood or tissue that you're interested in, and then you need this mass spectrometer to actually measure these stable isotopes. You can do it theoretically with radioactive isotopes, but in humans not really used anymore. Last thing that you can do is signaling, very popular. All these pathways, synthesis and breakdown, have all the signaling molecules that need to be phosphorylated. On the way down, you have the mTOR, the ACTs, and the ligation factors, and you have your PGC1 alpha, which is more in the mitochondria. I don't believe much in. I believe they're important, but they're not. They're used too much in literature as a surrogate measure for synthesis rates. Yeah? They're not the same. You can have upregulated signaling, but no synthesis there. Interesting when you want to know if synthesis has changed, where has it changed, which signaling has changed, but you can't use it really as an alternative for measuring real turnover. Muscle function, there's not much, the focus is getting more and more on function. It's always been mass mostly, so a lot of the results I will show are actually on mass. Measuring muscle function is reasonably easy. You can measure strength, which is mostly done in different ways on the legs. It's mostly used in research. What's becoming very popular in the clinical nutrition research in humans is this hand grip strength. All clinics, you see this popping up now, that actually they measure muscle function. And it's a reasonably good tool for the purpose of it. Then, of course, what is getting very popular nowadays is the functional measures. What does it actually mean for the patient? Can patients, when they go from the hospital, can they do things? So we use a lot of 6-minute walking tests. So patients come back, they walk 6 minutes, and you calculate how far do they walk. Or this kind of raising up from a chair test. How fast can you actually get up? How fast can you get up? How many times can you do this? So somehow try to quantify and measure the function that actually means something. But for the patients, this is, some patients get excited because they see it as a challenge to really go for it. Other patients don't care much about it. This is what patients actually care about. Can they do things in their normal home? Good, that's the methods. I'll take you through a couple of muscle wasting situations. Aging, as you all know, we lose muscle. It's very slow. Different studies have done this different ways, but it's a slow decrease in muscle mass that actually happens on all of us. And I call that actually healthy aging. You just have to accept it, I guess. It's mostly because your fibers, you get less of these muscle fibers, so they disappear. Then, of course, the function, and it's difficult, how do you present the function? I actually found this graph, which I thought was very interesting. This is the running speed of actually top athletes at different ages in the different distances, going from 100 meters to the marathon. And you see with time, the older these kind of top athletes get, the slower they're actually running. So it's a real thing. Yeah. Why is it then a problem? Sarcopenia and aging. It's a problem because of the variation, of course. Yeah. We all gain when we're young in adult life, depending on how we start to lose already, a little bit depending on what you do. It's here. The range gets bigger. We all lose, but it's when you get below this disability threshold when it becomes actually a problem. Yeah. And why is it a problem? It's a problem because if you're on top of having less function. If you're a healthy, fit, older individual, you get a minor illness, your function goes down, but you're very much able to recover from this. If you're at the lower side in the frailty, it hits you harder, and it's very difficult to get it back if you even get it back. And you get a few of these, you can see this patient just getting more and more into dependency. So this is the issue. And then, of course, that is where I think we should define sarcopenia. It's where the muscle loss and the aging is actually becoming a problem. How often does this happen? Then it turns out it's actually much more complicated. Wikipedia makes it easy. But then actually, if you put a number on it, then it turns out not to be that easy anymore. This is one of the studies, a Canadian study, large study, where they looked at the incidence of the prevalence of the sarcopenia as they define it. I'm not going into details. And you see in men and women, it's increasing with age. It's starting from below 70 and then up, both increasing, and it's both the sarcopenia and the sarcopenic obesity is there, up to numbers around 15-20%. Yeah. Then you ask other people to do the same thing. Somebody looked up, all this, did a systematic review of this, and depending on how people define it, you can get sarcopenia between 1 to 33% of the study population. So it's actually not that easy to define, to put a number to it. To actually say this patient, yes, this patient, no. We come back to my prejudice about balances. How is this happening in aging? There's some debates about this. Yeah? Some people have shown that baseline, so postprandial, the morning when you wake up before breakfast, there's already changes in synthesis rates. Other people don't find this. So it's been a debate for a while. I think the debate is settling that it's probably not the basal thing. This is a nice study where you see it's the balance again. Yeah? So it's the synthesis, it's the breakdown and the protein balance in muscle, in young and elderly. And you see here that actually baseline synthesis is not different, and actually it's not significant there either. Yeah? So the baseline seems to be similar. It's not where we're wasting. What happens if you then feed them? If we eat, our muscle synthesis really gets going. Yeah? If the elderly eat the same amount, it's actually not that much happening. Yeah? And this is what they then call, there's other studies showing that as well. Here's another study, more controlled, young and elderly with a real food intake, and you measure protein synthesis in the muscle, you see that the elderly have this kind of dampened response. And this is what we call, anabolic resistance. Yeah? A very important term, I think, coming back all the time. That you don't have the same anabolic response to, not the same increase in synthesis towards the same anabolic stimuli. A little bit more about function and aging. It's a study I've been involved in when I was just west of here in Minnesota. Young, middle-aged, and old, muscle function decreases, but look at it. Yeah? It's muscle function strength expressed per muscle mass. Yeah? So you get a decrease in mass and function for that, but per unit of muscle, you also get a decrease in function. So it's actually the quality of the muscle is also changing. To follow that up, we started to do synthesis rates. You see, I've been biased as well, just measuring synthesis rate. Of the different proteins that you have in your muscle, the kind of myosin heavy chain, so these are the contractiles. We looked at the more metabolic sarcoplasmic proteins, and then the mitochondrial. This was my part of the study, which I actually will not talk more about, unfortunately. So if we then correlate the muscle strength per mass unit to the synthesis rates of myosin heavy chain, you see a rather nice correlation, meaning that the different proteins behave differently in muscle and are affected differently by aging. Disease. So you see with aging that we get this decline all the time. That is there. It's partly due to this anabolic resistance that's probably there. But the main problem is when you're on top of this small decline, as I showed you earlier, you get these kind of diseases and inactivity that kind of give you this dip that you have to come out of again. And if you have a lot of these dips and you're already frail, it's a problem. So let's look a little bit about what happens to muscle with disease. This is not muscle, but it's a very nice illustration, I think. It's nitrogen balances, whole body nitrogen balances. With nitrogen balances gives you the loss of protein, which I guess is mostly muscle. But it illustrates very nicely that if you're getting sicker and sicker, hip replacement, sepsis, you get serious trauma, or you get serious burn injuries, the sicker you are, the more muscle you lose. Yeah? And like I said before, the extreme is in this kind of multiple organ failure patients that we study. And you see here that if you measure muscle mass, you get about 10 days in the ICU, you lose just over 20% of your muscle thickness. It's a lot. One of the problems is, of course, in hospitals that we put people in bed. Yeah? We think it's easier. People don't feel like moving. I sometimes wonder if it's not easier for the nursing staff to just have people in bed, then they know where they are. They're not walking around. That is a problem. Let me see. It's studied a lot in activity. There's different ways you can do this. You can put people actually in bed. You can put casts around the muscle, inactivate the muscle that way. Or you can actually do this kind of head down. It's more like NASA likes this because it's kind of a model for the in-space flights and the muscle wasting that you have there. In all these models and situations, you get a decrease in muscle mass compared with controls. This is only 5 days immobilization with a cast. And synthesis, both the basal and during the feeding, is lower in the immobilization state. Yeah. So you actually lose muscle mass by just immobilizing. It's actually, the surgeons are great, yeah, because they have now developed a system that's called ERAS. It's early recovery. So a lot of surgical patients are nowadays kicked out of their bed the day after major surgery to keep them up and get them moving around. Nurses, some like it, some think it's too much work, but it's really, you see recovery rates going down dramatically by just doing this. A little bit on cancer, cachexia. I just took one study. Looking both at synthesis and breakdown. And if you have, these are serious, these are not these are the esophageal cancer patients, very, very dramatic cancer and surgeries. Synthesis, maybe a little bit decreased in this group, but breakdown is up a lot. Yeah? And if you feed the patients, you see, compared with young ones, that if you feed again, you get this increase in synthesis, not much happens in breakdown, a little bit down. In the patients, not much happens. It's again this anabolic resistance coming up in the cancer patient. The cool thing about this study is that they repeated this after they cut out the cancer, and the patients actually fully recover into being able to respond to a feeding stimuli again. So the cancer has a huge influence on the cachexia that's happening there. A few slides on our patient group. Like I said, the dramatic wasting there. If we do the balances of muscle, we see synthesis rates that are basically normal compared to controls. These are young guys, fat. It's breakdown driving this. It's a massive breakdown. Yeah? And synthesis, if you look more carefully at these patients, their muscle protein synthesis, we have the world record ever measured in muscle protein synthesis. The highest ever measured is in a patient that's extremely sick. So here you see that measuring this kind of turnover on the balances is extremely important. We started to chase up a little bit. That's a lot of our research nowadays is into what is actually explaining this. So we did a study where we first thought, is it actually measuring muscle protein synthesis or measuring something else? So we did biopsies in 2 legs of the patients and see exactly the same thing. So it's not a heterogeneous problem. Then the only thing we can actually find, which is very interesting, I think, is that the high synthesis rates are in the patients that are longer in the ICU. And we've now done a dedicated study to show that actually it's the breakdown is driving this, but somehow some patients can compensate by increasing synthesis. Again, if we want to go and treat these things, it's important to know where your wasting is coming from. A lot of people think wasting is because synthesis is down. It is in a lot of minor diseases. Kidney failure, I haven't shown the data, badly treated diabetes, they are normally kind of a synthesis problem and an anabolic resistance. But if you get sicker, it's the breakdown driving this, and synthesis is actually normal or even high, trying to compensate probably. Important things to know. Feeding. So what does feeding do? We all know, I guess. We have kind of a balance in muscle during the day. We eat occasionally, and then we increase our synthesis, and the breakdown is going down, so we actually anabolic, and then a couple of hours later, you're not eating, you actually become catabolic instead of anabolic. And this goes up and down all the time during the day. And if you're an adult person, you kind of keep this almost, because the loss of aging, muscle in aging is a very, very slow and long process. So these differences are not very big. Talked a little bit about the anabolic resistance in the aging, that if you eat, you've seen this slide, you get less of a stimuli of synthesis. The reason for this is, not many people have looked at this. There's a group in Texas from Elena Volpe that have looked at this carefully, and they have some very intriguing results, I think. It's a complicated slide. It's synthesis rates here, and it's blood flow to the leg. Young people, elderly people, baseline measurements, and then they start doing things. I'll take you through this. So at baseline, synthesis are about similar, and blood flow is actually a little bit lower in the elderly. If you then you do an insulin clamp, so you give a high dose of insulin, you stimulate synthesis quite nicely, actually, in the young ones, but not in the elderly. And you see it's the same thing in flow. So it's a blood flow that is actually not responding to the insulin. If you then give high insulin, so you try to overcome this, then you're able in the elderly also to stimulate, and you stimulate blood flow just a little bit, actually. If you then make the young ones like the old ones, so you inhibit the increase in blood flow by inhibiting nitric oxide production, you give insulin, you see that there is no stimuli. So it seems this blood flow is important, actually, to have the protein synthesis. If you do that in the old ones, you kind of stimulate the NO production, plus the insulin, you see they can go up a little bit. So it seems to be an interplay about insulin resistance there on the blood flow that is partly explaining the anabolic resistance that we see in aging. Question is, can we overcome it? Can we give more protein, and does it help? It seems like if synthesis goes up, if you give more, this is essential amino acid, but also in the elderly, you can come up a little bit more. And then we come to this concept, which I think is rather interesting, of you need to come over a certain threshold with your protein intake to get a maximum anabolic response in muscle. And with aging, probably this increases. So if you give more proteins, and the studies backing this up, then you can actually increase this and still hit the threshold also in the elderly. And an intriguing concept around there is coming again from Texas, is this, that when do we have maximal stimuli? I'm not really sure if all the numbers are correct, but still it's an intriguing concept that you need 30 grams in a meal to come to maximum protein synthesis. And the way we eat in most Western countries, during breakfast and lunch, we don't get there. We don't come up. And then even in the aging, when this threshold is going up, it will be more difficult. So when they did studies spreading it out more even, they actually see better muscle synthesis mostly in those studies. I'm not sure if it's important to actually spread it out more. There's a very nice study done in France that I just saw an abstract, so I don't have the numbers, where they supplement breakfast in the elderly with a protein drink. So you whack this one up and you just leave the rest the same. And that is see actually improvement in muscle function happening in these patients. So this seems to be something to, especially in the elderly, to consider. I have 5 more minutes. A little bit on leucine. Leucine is special. It's very popular. It actually is a signaling. Here we can do some signaling. Leucine signals as the essential amino acids that initiates the signaling for protein synthesis. Then most studies show you on the side need all the other amino acids to actually make the synthesis happening. But it's probably in leucine that kind of says to the muscle, be ready, we're coming. And if you give leucine on top of a protein meal, you see actually that you get higher synthesis rates than just the protein on its own. And again, I think this is where this threshold is becoming interesting. I think it's the leucine that people show more and more that is making the threshold. So you need to come up to a certain leucine concentration to get the maximal stimuli of synthesis in muscle. And with aging, this is coming up. You need to get these probably even a little bit higher. And here's where the special proteins can make an impact. Because different proteins have different contents of amino acids. And the whey protein has a higher leucine content than most others. So this is actually, the top there is the whey protein. And if you look at whey proteins and give it to patients, you see this kind of, compared with casein, that you get a higher leucine concentration. And if you then measure, this is whole body protein synthesis, but still you show a higher protein synthesis due to the higher peak in leucine there. Does it work in elderly? Yes, together with training this is. I couldn't find another study. You're both in the young and the old ones, you're able, these are the young ones, these are the old ones, to stimulate synthesis a little bit more with the leucine compared with an alanine control group. Very boring slide, but again, very, very important. Important point coming up. All these studies I showed you are acute studies. You give something, you measure synthesis. You give something, you measure turnover. And many of the studies shows changes, but the leucine as well. But if you then do the long-term studies, because what we really want to know is, does this change muscle mass? So this is a study from Maastricht, where they did this in elderly diabetic men and gave them extra leucine on top of their normal diet for 24 weeks. You don't have to read all the numbers. Nothing happens. There's no more muscle mass, there's no more muscle strength. This is probably because these men were not cachectic. They had diabetes, they were elderly, but they were kind of healthy. And nobody gets as big as Arnold Schwarzenegger by just eating proteins. It's just not going to happen. So that brings me to the last little point. It's the exercise. You need to use the muscles together with the proteins to really make this happen. We know that training improves muscle mass and function. It's kind of, how does it work? I just have 2 studies to support this, that actually if you do the resistance training in this case, you increase the gain of the muscle synthesis mostly in combination with the protein feed. And studies show that if you just do training, you increase synthesis after 1 bout of exercise, also increase breakdown a little bit, but you kind of are in a positive balance. And if you do this, also the elderly respond. Both to a high protein meal, you get increased muscle protein synthesis, and together with the resistance exercise, you get a higher, so the meal plus the resistance, you get a higher increase in the protein synthesis, and it seems to be working in, as well as in young people as in old people. So, a couple of slides to sum it up. This, I think, is the most important, one of the most important slides. With aging, it's this kind of, when you're already frail, the minor injuries put you back. And if you have a few after each other, you get into this dependency situation, which is what most people dislike most with aging. And what I think we should do and focus on is not on trying to fix this. It seems to be extremely difficult once people are sarcopenic and frail to increase them in muscle function. We should really focus on this side of the story, which is done too little. We should prevent this kind of frailty as long as possible. And to do that, you need to know what is the reasons for the sarcopenia or coming to the frailty. I just listed them. We've talked about a few in the talk. There's a few that you can actually influence, a few that you can't. Decreased food intake in the elderly is actually a problem. There's higher recommendations for protein intake in the elderly, mostly to compensate for this decrease in energy that they have. Anabolic resistance, we saw. It's the threshold theory. I think there's interesting proof. It's not proven completely. It's the insulin resistance that I showed you. The decrease in anabolic hormones, probably not something we should interfere with, but you need to be aware of this. Comorbidities and diseases get more and more. They affect, you saw that on the diseases, they always affect your muscle wasting. All diseases kind of give you a drop in your muscle mass. And then it's decreased activity that often happens that you can actually work with. A couple of important points. The outside is not the same as the inside. We have this sarcopenic obesity. You can go wrong. You cannot see the sarcopenia in certain patient groups. Size doesn't always matter. It's the function. Here's a marathon runner over 70. His legs look almost the same. There's more functional muscle in there, but the size is actually not huge. The last thing, you can actually, this picture, I use it a lot because it shows the three things, I think, that can increase muscle mass. It's the training that he does, it's the protein feeding that he does, and it's the other things on the side that he probably is doing. Has been doing. To sum it up, my take-home messages for you is that wasting has serious consequences, especially if you're elderly and you get into this kind of dips down, you come in a dependency situation, life is not fun anymore. This is with the methods. I think I heard somebody say, this is not my own quote, I stole it, that we have to make the important measurable rather than the measurable important. We tend to, with the synthesis rates, it's easier, so that's why we measure it. But it's the breakdown that we're also interested in. More complicated, but yeah, that's life. Healthy aging, you always lose. And I think it's actually important that we kind of try to find out how we can intervene with these huge drops, that we don't get into the frailty and then try to get people out of the frailty, which seems to be very problematic. And all diseases will induce muscle loss, but the mechanisms are different. So if you want to intervene in the specific diseases, you need to know the mechanisms, in my eyes, of the losses, so you know where you should be intervening. And that's all I had to tell you about the human muscle research.